Okay, guys, welcome to the third episode in the Usmle in less than 10-minute series. In the last episode, we talked about acute and chronic pancreatitis, and today we're going to move on to pancreatic adenocarcinoma. So make sure you guys watch the last videos before continuing with this one because it'll just make more sense. So to begin with, let's begin with the risk factors. You should remember a couple of them. Number one is race. You have to remember that it's increased in African Americans and those of Jewish descent. The males have an increased chance compared to females, and as you increase in age, so do the chances of you getting pancreatic cancer. Some of the other risk factors that are outside of your control include smoking. Smoking increases the chance by 6-fold, and that's the most important one. I've done many questions, and I've seen that smoking is tested the most. So remember that smoking is increasing the chances of getting pancreatic cancer. Chronic pancreatitis, one for a prolonged time, we talked about that in yesterday's video. The increased inflammation over a long period of time predisposes to pancreatic cancer. So it's got to be like greater than 20 to 30 years. And finally, obesity, like type 2 diabetes mellitus, also can increase the chance. But just remember African American race and smoking. Those are the two most important. So there's different subtypes of cancers in the pancreas. We have the endocrine cancers, like including insulomas, glucagonomas, but today we're talking about the exocrine cancers. The most common subtype of the exocrine cancer is a ductal adenocarcinoma. In 95% of cases, patients are going to have ductal adenocarcinomas, and in 5%, it's going to be acinar adenocarcinomas. So, the pancreas is different parts. As the head, the body, and the tail. Most commonly, pancreatic cancers occur in the head of the pancreas, so remember that. And over here is a picture of the histology. I circled for you. You can see how the cells over here are cluttered and basophilic and disorganized. If you look at a picture of a normal pancreas, it won't be like this. So the presentation is going to be like in any cancer. You're going to have constitutional symptoms like weight loss, fatigue, decreased appetite, even mood changes. So that's often the first clue: unintentional weight loss, as it is in all cancers. Malabsorption, we discussed in chronic pancreatitis. One of the functions of the pancreas is to release digestive enzymes. So when the pancreas isn't working, we can't release these enzymes and we can't absorb the food, so that leads to malabsorption. Obstructive jaundice, if the tumor is in the head of the pancreas, it can obstruct the common bile duct and the biliary system, leading to the leakage of bilirubin into the blood, causing jaundice. Epigastric pain isn't that common, but it can occur. And glucose intolerance, if the cancer gets really bad and starts to involve most of the pancreas, it can also affect the insulin-producing cells, the beta cells of the pancreas, and you'll have diabetes-like syndrome. And it's also very important to remember two important signs: Courvoisier's sign and Trousseau's sign of malignancy, and we'll talk about that next. Trousseau's sign of malignancy is tested often. It's due to a hypercoagulable state. You know that in all malignancies, cancers increase the chance of clots forming. They cause the body to be in a hypercoagulable state. So this causes widespread superficial migratory thrombophlebitis. Basically, what happens is that you'll get thrombophlebitis in the leg, and it'll then move to the arm. And the patient will complain of this, and oftentimes this can be like the first presenting sign. So we talk about Trousseau's sign. Trousseau's syndrome is when a malignancy is also present as well. So Trousseau's sign is just the presence of migratory thrombophlebitis, but syndrome is when it's the sign and a malignancy is present. And it's often the initial presentation of pancreatic cancer, and this is what it looks like over here. Courvoisier's sign is basically telling you that in the case on physical exam, if you have an enlarged gallbladder and it's painless and there's presence of jaundice, the cause is unlikely to be a gallstone, and the more likely cause is to be a tumor in the head of the pancreas. Gallstones often cause painful jaundice and painful enlarged gallbladder. So if it's painless and the gallbladder is enlarged and there's jaundice, it's probably not a gallstone and you gotta look somewhere else. In this case, pancreatic cancer. Diagnostics and treatment. The first step would be to evaluate the patient clinically. You have to listen to what they're complaining about. If they tell you about weight loss, if they're having fatty stools, diarrhea, if you can figure out one of the vitamin deficiencies, A, D, E, and K are fat-soluble vitamins, and you need pancreatic enzymes to absorb them. So that can be the initial presentation. From there, usually you have to do a CT, and you have to confirm with the biopsy to confirm the location and histology. The serum tumor marker CA19-9 is useful because it's elevated in pancreatic adenocarcinomas. CEA can also be elevated, but it's less useful than CA19-9, and this is also often tested as well. So the treatment's going to be you supply the enzymes for malabsorption, a supportive treatment. But if the tumor is large and it's causing discomfort, it's causing jaundice, and if it's in the head, you can go on with surgery, and of course chemotherapy and radiation for all cancers. So the surgery that they perform in pancreatic adenocarcinoma is something known as a Whipple procedure. You perform this when the tumor is in the head of the pancreas, and what you're doing in this procedure is basically you're removing part of the stomach, the gallbladder, and the bile ducts, the head of the pancreas, and the duodenum. And you're getting rid of the cancer, and you're basically making these different anastomoses. So as you can see in this picture, the biliary system is removed, and the bile ducts is connected directly to the jejunum. The duodenum has been removed, the stomach has been connected directly to the jejunum, and the pancreas has been directly connected to the jejunum. And this is called the Whipple's procedure and is often used. And finally, high yield risk factors, remember that, smoking and African American race. There's also gene mutations that can be tested. Mutations in tumor suppressor gene SMAD4 can also increase the chance. Mutation in proto-oncogenes CRAS, so remember that. Remember trusosine, because oftentimes they can just give you a picture of the migratory thrombophlebitis, and you have to think what's going on and make a connection with pancreatic cancer. Tumor marker CA19-9, it's more useful versus EEA, and of course the Whipple procedure. Okay, thank you guys, and make sure you guys like the video and tell me what you want to see next.